Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back, everyone. Today we will be talking about an interesting paper comparing laparoscopic surgery and radiofrequency ablation for small cell hepatocellular carcinoma. This will be followed by a teaching session on master protocols for randomized controlled trials. This is the third session on multi-arm RCTs, which we'll conclude next time. They're talking of adaptive design and multi-arm, multi-stage RCTs. I'll leave you to it.
So good evening, everybody. My name is Achita. Today we're going to be talking about a paper published in BJS titled Laparoscopic Liver Resection versus Radiofrequency Ablation for Small Hepatocellular Carcinoma, randomized controlled clinical trial. I will hand over to Gio to talk about the paper a little bit.
Yeah, let's have a look at the background for this. Now, obviously, I studied HCC guidance for my exam, but that's pretty much as far as my experience goes. I've not been dealing with livers for quite some time now. But certainly there are a few guidances out there. British Society of Gastroenterology has recently updated theirs. And as you can see, ablation does not seem to figure as a particularly popular type of treatment, particularly for HCCs in the size 2 to 5 centimeter, which are part of the trial in this particular paper we're discussing today. Guidelines that apply to China particularly are quite different, and they do talk about ablation as a potential technique for HCCs less than 5 centimeter. And finally, American guidelines, which originally did recommend ablation more liberally, have recently moved towards a more surgical type pathway for relatively small lesions. So certainly this paper sits in a relatively controversial area where new evidence is welcome, particularly for relatively less invasive procedures such as RFA. So hopefully we'll have some more information by the end of this presentation. Bolto Suchita for some PICO.
Yeah, so looking over the PICO, the population the paper dealt with was essentially adults with small HCCs. Now, the intervention and comparison was not made clear in the paper, so I understand it as the radiofrequency ablation group was the intervention and the liver resection group was the comparison. The primary outcome was overall survival, and recurrence-free survival was the secondary outcome.
So let's have a look at the design. This was a single-center randomized controlled trial with an attempted assessor blinding, and we will say why I say attempted later on. Randomization was conducted in a one-to-one manner. They didn't use blocks, they didn't use stratification. And you can see the center where this work originated from. It's a tertiary high-volume center in China. Recruitment was between September 2014 and November 2015, so a relatively small time window, actually, considering the number of patients they've got in the study. The sample size were based on retrospective data from the same institution, suggesting that 5-year overall survival for laparoscopic liver resection would be 78.1% and RFA 65.7%, suggesting a degree of superiority in the primary outcome for laparoscopic liver resection, perhaps. I couldn't quite work out, based on the way they described the sample size calculations, what type of design they employed here, but we'll talk about it in a minute. So, Bolto Suchita for some inclusion-exclusion criteria.
So the inclusion criteria for this study was essentially patients who had a singular nodule that was no larger than 5 centimeters or 3 smaller nodules of 3 centimeter or less. The key inclusion criteria effectively covered all patients who may have been decompensated because of their HCC, so involving decompensated cirrhosis, varices, as well as portal hypertension. The non-hepatic primary didn't make that much sense to me because it wouldn't be a HCC anyway. Now, they did change their study design about 3 months into the study, which makes me wonder about the effectivity of the study itself, but we'll discuss that in a second. They increased their tumor diameter to 5 centimeters, increased the sample size to 150 patients, and extended the follow-up to up to 5 years.
So let's start diving into some results. They considered over 700 patients for inclusion, but they ultimately randomized 150. And as you can see, as expected, they split allocation 75 and 75. And as you can see, a reasonable amount of these patients actually underwent the procedure that they were allocated to, and also very few were lost to follow-up, only 2 in the laparoscopic liver resection group and 1 in the RFA group. So ultimately, very good effort, I would say.
Just looking at some of the baseline characteristics they've mentioned as part of their results, what we want to highlight here is that actually the underlying pathology of patients who develop HCC in China seems to be very different to that in the UK. As well as if you note the size of the tumors, so smaller tumors were effectively put in the RFA group versus the laparoscopic resection group. And overall, I would say that the study found similar overall survival and recurrence-free survival between both the groups, with some differences between the patterns of recurrence. They did identify positive prognostic factors for overall survival as well as recurrence, which were tumor size as well as ICGR15 values.
So we're going to dig a little bit more into the results, and particularly the primary outcomes. So they did reach a median follow-up of 60 months, which effectively is 5 years, which is what they wanted to achieve. They had 43 deaths in total, 19 deaths in the LLR group and 24 in the RFA group. And if you look at the survival curves, it does feel like the 2 interventions are relatively comparable to each other, and the number of patients at risk towards the 60 months mark is actually pretty good. It does perhaps give you the impression that given enough time, perhaps the 2 curves would split. Obviously, we can't say, but there is further evidence in their secondary outcomes that might suggest that that could be the case. So secondary outcome, if we remember, is a recurrence-free survival. And as you can see, the tendency here is for RFA to be oncologically inferior, just looking at it graphically, really, although this was not statistically significant. 35 patients had recurrence within 5 years in the laparoscopic resection, 42 in the RFA group. The distribution of those recurrences was similar, intrahepatic or distant. There were some differences in terms of where those recurrences happened inside the liver, presumably because RFA is a more localized technique, so there's a tendency for slightly more local recurrences at that level. Ball back to Suchita for some limitations.
Yep, so the authors have mentioned certain limitations. First, they comment on their sample size being small, which can, of course, affect the generalizability of the results. The follow-up duration, they've mentioned, can be a limitation, as, of course, you can get recurrence or death from the primary tumor after 5 years. Within the RFA group, of course, since using radiofrequency ablation, there was no possibility of getting histology samples. So there was no data on that. And they also comment on the lack of statistical power to detect clinically significant differences between the two groups?
There's a few more limitations that we felt are worth mentioning. We said that at the outset, this is a single center study in a high volume tertiary center. The authors describe very well how the two techniques, laparoscopic liver resections and RFA, are very well standardized, and patients that undergo RFA, if they have what appears to be a radiological incomplete ablation, they undergo a further ablation at 72 hours, which I feel is quite impressive. So their results might not necessarily be replicable in Western, even tertiary centers that just don't have such high volumes of HCCs. There is a degree of heterogeneity in the patient populations, although despite this being a randomized controlled trial, and Suchita mentioned earlier on, looking at the baseline characteristics of the patients, there seemed to be a tendency for RFA patients to have smaller HCCs. Obviously, this is just due to chance, but it could have affected the results. We did feel that secondary outcome assessment was probably not blinded. Obviously, the primary outcome here was, being alive or being dead. And we can safely say that whoever's assessing that can be blinded in that context. But for secondary outcomes, a radiologist that's looking at staging CT scan and picking up recurrences would certainly be able to understand if a piece of liver has been removed or not, or if an RFA has happened or not. The authors don't get into details on how they removed that information from a report, or how they somehow managed to achieve blinding in terms of reporting of secondary outcomes. We did think that changing the study protocol 3 months into the study, although the authors justified their choice by saying that the guidelines do include HCCs up to 5 centimeters as potentially suitable for ablation, we did feel that it potentially introduces a selection bias. The patients that were recruited at the start of the trial in the first 3 months were still included in the study, as it was felt that the original inclusion criteria were effectively a small subgroup of the overall inclusion criteria, so they didn't feel like excluding them, which, to be honest, I don't have a major issues with. But I couldn't fully work out, and I mentioned this already, what the design was about. Was this a design aimed at demonstrating the superiority of laparoscopic liver resection? Was it a non-inferiority design towards RFA? Certainly there's an argument in looking at RFA as non-inferior, as it is a less invasive treatment, although we don't have much data in terms of adverse outcomes from treatment that the authors have provided. And so bottom line, I couldn't say what was the intervention and what was the comparator, which to me is a bit of an issue because it doesn't make the research question, it means that the research question is not super clear. I'm not sure this is relevant now, given UK and USA guidelines. The USA guidelines have changed, and they used to be more liberal in offering RFA. Now they have moved away from it for a number of reasons. So I'm not sure this study is still relevant now, but it might well be. It might be that we will go back on that. And certainly we talked about external validity. I am not sure the population that is studied here, given the significant number of hepatitis B-related HCC, is translatable into the UK reality, where the vast majority of HCCs are from alcohol-related liver disease. And finally, maybe a slightly mean comment. The sentence you see in between question marks is at the opening session of the results. The authors say, and this is just a sentence on its own, that median overall survival was not reached in either group. And I'm not sure what that means. I've read this with Suchita. I read this with a couple of other colleagues, and we couldn't just work out what that meant. So maybe we will ask the authors. So ball back to Suchita for some conclusions.
Thank you, Gio. To conclude, I think this paper does provide a lot of information between the effectiveness of laparoscopic resection versus radiofrequency ablation that can further influence guidance. However, I do think that the methodology could have been better, and there are potential biases and study design issues that should be considered when we interpret these results. I think we certainly need further research into this with a better / larger sample size and better study design, if we want to get more evidence backing radiofrequency ablation. And on the table you see below were just our thoughts on what went well and what went not so well with the paper. And I think that brings us to the end of our presentation. Thank you.
Thank you.
As usual, a brief summary of what we discussed during the discussion about the paper. So, as we kind of mentioned in the presentation, we could not fully work out what type of RCT this was. The general feeling is that this might well be an equivalence trial. But a non-inferiority design was also deemed to be potentially reasonable given the relatively low invasiveness of radiofrequency ablation. We furthermore discussed the generalizability of the finding of this study given how super specialized the center where this data comes from is. And we also mentioned how there appeared to be a sort of tendency for smaller tumors in the RFA group, as we mentioned in the presentation as well. A further point that we discussed was about blinding for secondary outcomes, which we felt was important. And finally, we discussed how this paper could fit with international guidelines, moving away from RFA for HCC, and finally the role of microwave ablation in the setting of HCC, which the authors don't mention. We will be discussing all this with the authors through a letter to the editor. We'll let you know.
Let's start by defining what a master protocol is. So a master protocol is a protocol that allows you to study multiple therapies or multiple disease subtypes at the same time and or over time. A fairly cryptic definition, I would say. This is from the Global Coalition for Adaptive Research. You can see the websites down at the bottom right. And it's basically an international group of researchers that are promoting the use of master protocols and particularly the adoption of adaptive randomized controlled trials. And we'll talk about what all this is in a minute. So before we go into what actually this is about, we probably need to understand that there is a little bit of a philosophical difference between what we have spoken in the past couple of sessions and what we're going to talk about today. Generally, when one researcher approaches a disease or develops a specialty interest or whatever, there normally are not just 1 or 2 questions, but 1,000 unanswered questions. They might be about biochemical markers, they might be about efficacy of particular types of treatments, etc., etc. And certainly when they're looking at all these questions, they've got various ways of dealing with it. One is what we call standard, if you like, or multi-arm RCT. It allows you to look at one specific aspect of the disease or one particular intervention. It allows you to run 1, or as we saw in the past couple of sessions, maybe 2, 3, 4, 5 comparisons. It normally works in a very pre-specified time frame with a very tight protocol, and it can become, unfortunately, old by the time it ends, especially when you're talking about diseases or treatments, molecular treatments particularly, that evolve and come up at the speed of light. So when we talk about master protocols, we address some of those problems, And we look at something that focus not so much on one specific aspect of the disease, but rather on a disease or a group of diseases altogether, and allows you to run a variety of comparisons, a variety of tests, or a variety of efficacy studies on a number of interventions or things that you can do for that disease as a group, which is a massive philosophical difference if you think about it. Also, some of these protocols have no specific time frame, and we'll go into some details about that. And some of those protocols allows you to introduce new treatments as you're going along. Now that we understand that, let's have a better look at what a master protocol is. So a master protocol is an overarching protocol designed to answer multiple questions. And like everything in life, there's different types of it. One is the umbrella protocol that allows you to look at multiple targeted therapies in one disease, and we'll go into some examples in a minute. Basket protocols that pretty much do the opposite. So they look at one targeted therapy, but in a number of diseases or type of a particular disease. And finally, platform. Platform look at multiple targeted therapy in what is described as a perpetual manner. And again, I understand I'm probably speaking a bit of Arabic here, but hopefully with some examples as we go along, we'll understand this a bit better. So let's start with umbrella, reiterating again, multiple targeted therapy in one disease. For a change, we are going to have a look at colorectal cancer as an example. So as you start your career as a surgeon and you go into looking at some colorectal resections and stuff, you think, oh, well, this is all pretty simple. A patient has a cancer, we either take it out or we give them some chemo, or we give them some radiotherapy or whatever. Then as you go along and maybe you're approaching your exam and stuff like that, you actually realize that the story is much more complicated. This is an extract from one of the BSG documents about the evolution of colorectal polyps. And it's here predominantly to remind us how many biochemical, biological, and a number of targets are there that could potentially be the subject of a new treatment. And certainly there's much more complexity than I thought when I was in my early years of training, and we thought 10, 15, 20 years ago. So certainly we have to ask ourselves, well, how do we reconcile all this complexity into research that is adequate for this, adequate to address all these problems, all these questions? How do I know that a treatment works for a cancer that originates from a conventional FAP pathway or a Lynch pathway or a serrated pathway? It's really hard. It's really hard. And that's where umbrella protocols comes in. And this is an example of an umbrella protocol. It's from the FOCUS-4 study. FOCUS-4 looked at advanced or metastatic colorectal cancer and included all patients that were fit for first-line chemotherapy. As they were having their chemo, all these patients underwent biomarker analysis. And as you can see in the diagram, a number of sub-trials were then designed to address different questions based on different biomarkers identified. And the disease that they're looking at is metastatic or advanced, CRC. Treatments are all fairly new, and they are assessed for efficacy as you're going along. So all these trials start as phase 2, and if the phase 2 is adequate, they move on to phase 3 directly without needing any more protocols, writing, without needing any more paperwork. It's just a simple pre-planned interim analysis. Ineffective treatments, they just get dropped away. And furthermore, you can add additional arms as you're going along. And this is pretty much what the author did. This is the timeline of the all FOCUS-4. The first trial that actually was activated was the FOCUS-4D and the FOCUS-4N. So if you look at here is the two arms on the right side of the screen. So the all wild type and the non-stratified. The other arms started later in time, and they closed at different times, and they were published in different papers. So you can see what the advantage is here. You can plan for a variety of treatment strategies in a variety of different diseases subsets, all within one protocol. It expedites the assessment of new drugs, and it also makes it more captivating for recruitment. Patients tend to engage more in trials that are more likely to get them allocated to a trendy treatment. Obviously, there are issues, but we'll talk about them as we go along. So, to summarize the theory again, one disease, you screen for the presence of targets. In this case, we talked about the colorectal subgroup analysis, and then you divide your patients into different targeted therapies based on their biomarkers. Okay, this is just an example, but you can think of other instances where this would be relevant. Now, let's move on to basket protocols. Now, basket protocols, as we said, they do the opposite. So they look at a single therapy in the context of a number of diseases or disease subtypes. To understand this a bit better, we're going to talk about aspirin. Now, aspirin, because it's been given so widely in the context of cardiovascular prevention, etc., has been linked to a number of benefits in a number of different types of cancers. Prostate cancer, colorectal cancer, gastric esophageal cancer, and breast cancer, for example. Aspirin is appealing as a treatment option, is very cheap, is well known and accepted to the public as a medication, and certainly if it does really work in the context of any cancer, because they do share a common biochemical pathway in the evolution of the cancer itself or the evolution of metastasis, for example, then it would be an ideal drug to explore. And that's exactly what AD-aspirin trial is about. So the AD-aspirin is a basket protocol randomized controlled trial that looks at 4 cancers: breast, colorectal, gastroesophageal, and prostate, in 4 different sub-trials, basically, with 4 different primary outcomes. For breast cancer, it looks at invasive disease-free survival. For colorectal cancer, disease-free survival. For gastroesophageal cancer, overall survival. For prostate, biochemical recurrence-free survival. So basically, all these patients that are in this basket trial are linked because the treatment pathway that they receive is common. It's aspirin. But the disease is not common to them. And each arm in this trial does have basically 2 questions. The first one is, does aspirin work versus placebo? And when aspirin does work, at what dose is best, 100 or 300? And I'll give you an example where we perhaps should have done this to an extent, and that would be the CAPTURE trial in Lynch syndrome. We know that aspirin works in Lynch syndrome in reducing the risk of development of colorectal cancer, but we are still scratching our head about what is the right dose to give. And if we had embedded all the caveats that they have done in a similar design, allowing for a subgroup of Lynch patients, perhaps we might have had the answer. Obviously, these protocols have come up relatively recently, or have gained popularity relatively recently. So it's just a theoretical thought, really, more than anything else. So to summarize again, basket protocols, a number of diseases, they have one target that it's in common, in this case, presumably COX, and we give them one intervention and we just look at them as things go along. Let's talk about platform. Platform trial, again, the third type of master protocol, look at multiple targeted therapy in one disease in a perpetual manner. And therapies can enter or leave the platform. Now, this is probably the most complicated one of the 3, but I'll give you an example that certainly will help us understand why it is important, why platform protocols like this are very important, and that's COVID. Now, when COVID happened, we were all scratching our head of, whoa, what's working here? What can we do here to make things better? we have a battery of things that in theory could work, from steroids to antiretrovirals to this, and that, and more. Certainly, there's just 4 drugs that are considered in this table, a number of treatments: plasmapheresis, hydroxychloroquine, anti-inflammatories, and immunotherapy, and the more the merrier. But we needed answers pretty quickly, and that's where a number of these platform trials actually gained a lot of popularity. They existed before COVID, but during COVID, they gained a massive amount of popularity. And this is an example, the I-SPY COVID. So I-SPY COVID was looking at severe COVID and a number of interventions that could potentially help in reducing mortality in this context. All of the arms in I-SPY had the same backbone. Backbone is the standard of care, which was, if I remember correctly, steroid and an antiretroviral. And that is what all the patients received. A number of other arms were designed with multiple options to allow for testing at the same time, and new treatments were added as we were going along. To give you another practical example, we look at Principle. Principle is it comes from the University of Oxford, and this is the timeline of Principle 2 years after it started in March 2020. And as you can see, in May 2020, one arm was dropped because it was felt it was not useful. And in 2021, a further arm was added. And in June 2021, the same year, a further arm was added. So this type of platform protocols allow you to be very dynamic in a reality that very quickly changes, to adapt your randomized control trial to the current situation, remaining adherent to your protocol, and at the same time maintaining the credibility of the trial itself, because the trial was designed to do this in the first place, if that makes sense. Obviously, none of what I've said today is free of issues or problems. And the FDA very recently in December has actually put out a set of guidances on how to employ these master protocols in the development of new drugs. And if you go on the FDA website, you'll find that this guidance actually contains a reasonable explanation of master protocols, as well as a audio critique as well. And certainly there are a few issues about master protocols that we should bear in mind. One issue is blinding. Now, we are looking at patients that are included in the trial on a rolling basis, particularly for platform trials. And as arms multiply within the platform trial, the authors and the researchers will want to make some of the results public. That is because there might be, disease or practice-changing findings there that needs to come out to the public, that needs to come out to the researchers. But obviously, by doing that, they will unmask some of the blinding of at least some of the control patients. And it becomes difficult to then maintain blinding for the other arms and for the rest of the trial. And there are tips and tricks on how to do it, and certainly this FDA guidance is quite useful on that for design purposes. I will not go into details. Randomization is another issue. If you introduce a further arm into your trial, when your trial has already been running for a year, are you able to compare the new patients that you're putting in with controls that predate the insertion of the new arm? Well, in some cases you should, in some cases you shouldn't. And it's all about discussing and making sure that that question is answered before you start actually using the comparator arm when you're introducing a new arm. Difficult to say. Every situation should be looked at for itself. And finally, multiplicity. Multiplicity is an issue. We spoke about it in the previous couple of lectures I've delivered. When do we correct for it? Now, the general feeling from the FDA guidance is that if different arms are included with a common comparator, they effectively are sub-trials, and therefore correction for multiplicity would not be necessary unless a specific subgroup analysis is performed, or there are multiple comparisons done within the same group of patients. And that is kind of the simplified answer. So that's the feeling in general. However, there is another issue that is not addressed by the FDA guidance, but that I do feel is commonly perceived by a lot of surgeons that are talking about this type of protocols, and is perception. If you look at some of these trials, particularly the platform trials, you can't help but think, well, what is stopping them to do just whatever they want? Are we not just losing the rigor and the principles of RCTs and sort of underlying seriousness of research when we are just shoving in some new treatments every now and again? And the FDA guidance to an extent addresses this, because it does set out a very good framework on what researchers that look at new drugs should work with. But nevertheless, it is a problem. And I'll give you an example that does not relate to platform trials particularly, but relates to changing protocols as we go along. I'm sure most of you will be familiar with Foxtrot, and a trial of chemotherapy in advanced chronic cancer. One of the main criticisms that people move to Foxtrot is that their inclusion-exclusion criteria and the protocol have changed across the study period 3 times. And certainly it is a criticism, but also it was necessary to keep up with the evidence that was coming out, and to make sure that certain patients that clearly were not benefiting from what was going on were not penalized by their inclusion in the study. Nevertheless, what a lot of people perceive is that the protocol has changed, so the trial must be a bit rubbish. And certainly there's an argument there, but maybe it's not that strong. So to summarize, today we learned what a master protocol is. We looked at subtypes of master protocols, again, those 3. We look at advantages and applications, and we look at issues that can affect them. And next time, we're going to look at adaptive techniques. So techniques that can be applied to platform trials to make them even more dynamic, to make them even more cutting-edge and able to adapt to what is going on in new drugs development particularly. That's it for today.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.